A very good evening, everyone. So we are back again, and this time the target is FMGE. We all know the D-Day is approaching very fast, very soon. So now, as I always say, we're just about a month short of the target, and we must make sure that we are on the revision mode. As I always say, from now onwards, the days that are left is revision, revision, and more revision. Right? If all is working well, if there is no problem with the audio visual, if somebody can please confirm it so that we can get started. Hi, Rishi Raj. Hi, YouTuber. So basically, I have an important announcement to be made. That is the details of which will be towards the end of the class. Before I make that announcement, let others also join us. And meanwhile, let's see what Unacademy has to offer us this time. It has bigger savings unlocked. 25%. Yes, you got it right. It is offering, Unacademy is offering 25% off on all the Unacademy subscriptions. Maybe it is next, or maybe you're targeting FMGE. So, but this is valid only till the end of this month, that is till 30th June. So do not forget 25% off on all the subscriptions, right? And you can use the code Bhumika for all the added benefits. Then, as you can see on the screen, we have NEET PG Vitals. These are the recorded videos for you to see, for you to learn, for you to make notes at your own comfort. Whenever you have time, you can discuss them, you can see them, and whenever you have any issues, it is easily approachable. The educator is easily approachable through the app, through the Telegram groups. So it becomes quite interactive, even if you're seeing after the live classes. So even the recorded ones, you're able to solve your queries one to one. So that is 800 plus hours of recorded classes targeting NEET PG, which has the clinical based questions, previous year questions, and image based questions. Then again, for the next aspirants, we have ACE next, which is again 200 plus classes and 400 plus hours, having a comprehensive coverage of all these subjects. Then the last one, I say this is the FMG final frontier for July 2023. We all know 30th July is the D-Day. So we have limited period offer, we have limited seats, so grab before it is gone. And as I said, hello, Dr. Swami. A very good evening. Well, the important announcement that I have is that I am planning, I will be taking an advanced ophthalmology course at the Unacademy app. That is basically for the FMG aspirants. That's an advanced ophthalmology and edge over the others, which is a short course of 1.5 hours each, two sessions. The topics to be discussed will be I will be discussing, I will be talking to you towards the end of the session. So those topics will be divided into two sessions, which are 1.5 hours each, and is on the Unacademy app. That's a plus course for the FMG aspirants, and that is an edge over the others. Considering it to be in advanced ophthalmology, you want to have a step over others. We'll discuss those topics there. So meanwhile, I will discuss those details, those topics to be discussed in those two sessions towards the end. So if you like it, you can enroll in for that program. And meanwhile, today I said FMGE must knows is what we are targeting today. All right, so let's get started. So basically, you have to identify what is shown in here. Dr. Pandey, when that is for before 30th of July, that would be most probably on July 11th, one session, and July 18th, the second session, right? So these are the two sessions that we are targeting, 1.5 hours each. Okay, so the rest of the details towards the end of the session. So yeah, and this coming to the image, you have to identify what is shown in this image. Identify what is shown here. Tell me, what do you see in this image? What kind of a lens is this? Identify this lens. All right, I'll zoom in if you want me to now. Is it easy? Anything you can see here? Anything special which is seen here? So now you have to tell me what kind of a lens is this? We have discussed this so many times in our courses. Tell me, what are these three dots here and here? You can see these three dots here, three dots here. So if you try to join them, this forms a certain axis. This forms an axis. So what is this? Now, any hints? What kind of a lens is this? Anyone who wants to attempt? Okay. So basically, this is a toric lens. This is a toric monofocal posterior chamber IOL. This is a toric lens, which is a posterior chamber IOL. And how do you identify? You identify them from these dots here. You see these dots here and you see three dots here. So basically, these dots signify the axis. That means by toric lens, we mean they are used for the purpose of astigmatism. Right? So we all know that we have monofocal lenses, we have multifocal lenses, we have posterior chamber lenses, we have anterior chamber lenses, we have iris claw lenses. And when we talk of astigmatism, when we talk of this difference in the refractive error in the principal meridia, when we talk of astigmatism, we use toric lenses. And how do we identify them? We identify the toric lenses by the presence of these dots. So these dots are basically the axis of the cylinder, right? So whenever you get these dots in the on the IOL, they signify the axis of the cylindrical power. And these dots, whenever you see these dots, they say it is a toric lens. What do they say? They say it is a toric lens, and this toric lens is used in astigmatism. Is that clear? Is that okay? So this is a toric lens which is used in astigmatism in cataract surgeries, right? All right. So now we come to the next question. The nerve placed outside the muscle cone. Very, very important. Let's see. So what is it asking? The nerve placed outside the muscle cone. All right. So what are the different form of questions that can be asked like this, which will have the same impact, the same answer? The nerve placed outside the muscle cone, or if the question says the nerve which is spared during the retrobulbar block, or muscle the action of which can be seen after the retrobulbar block. What is the answer to this? So Lavanya says the answer is B. So Lavanya says the answer is B. That means she says it is fourth nerve. You're absolutely right. The answer is fourth nerve. So the fourth nerve, which is the fourth nerve? Fourth nerve is the trochlear nerve. It is the trochlear nerve. So when we talk of trochlear nerve, which muscle does it supply? Tell me. All right, so now there is a confusion. Some say it is C, some say it is B. Well, the answer is B. It is the fourth nerve. It is the trochlear nerve. Which muscle, tell me, which muscle does the trochlear nerve supply? Very good, Chandani and Lavanya. It is superior oblique. So they supply, trochlear nerve supplies the superior oblique. Very good. So now you need to understand, suppose this is the muscle cone. This is the muscle cone where you have superior rectors, you have inferior rectors, you have medial rectors, and you have lateral rectors. So this is the muscle cone from which this is the orbital apex. This is the orbital apex from which everything comes, all the nerves comes from the superior orbital fissure, inferior orbital fissure, and the optic canal. So basically, the important thing that you have to remember, that all the muscles are innervated, or the nerves, they come from the muscle cone. So all the muscles are innervated from inside to out. Right? So they are pierced from the inner side. That is the one which is towards the globe, except for the fourth nerve, except for the trochlear nerve, which supplies superior oblique. And please remember, so the fourth nerve, the trochlear nerve, comes from above and supplies the superior oblique. So once it comes from above and supplies the superior oblique, so it is outside the muscle cone. And where do we give? So if you think, if you just imagine, if this is the muscle cone, so this is the area where we inject when we give the retrobulbar block. So anything which is going from here, all the nerves which are going from here would be affected, except for the trochlear nerve, except for the trochlear nerve. So the trochlear nerve, I told you, supplies from outside. It supplies from the upper part. It supplies the superior oblique from the upper part. Hence, it is not within the muscle cone. Hence, it is spared. So again, I remember now there should be no confusion. So the nerve which is placed outside the muscle cone is fourth nerve. The nerve which is spared during the retrobulbar block is the fourth nerve. The muscle, the action of which can be seen or can be elicited even after the retrobulbar block, is the superior oblique muscle. Is that clear? So you know now why? Why? Because all the nerves, they innervate the muscles from the inner surface of the muscle, from the below under surface of the muscle, except for the superior oblique, where the trochlear nerve pierces from above, and hence it is not blocked when we give the block in the muscle cone. Is that clear? Give me a thumbs up so that I can move forward. Is this concept clear to you? So now this should not be wrong, okay? So the answer here is, what we learn is the trochlear nerve. So the answer here is the trochlear nerve, and they ask you the muscle would be the superior oblique muscle. Is that clear? Give me a thumbs up. If it is clear, I will move ahead. Okay? Good. Thank you, Dr. Kishore. All right. So now identify this image. What image is seen here in the picture? Thank you, Lakshmi, Chandani, Lavanya, for reassurance. All right. So now we move on to the next question. Tell me, what do you see in this image? Which investigation is this? Okay, you say this is corneal gatte. Well, what I need to ask you is, what I am asking you is, you have to identify the investigation. Tell me, what investigation is this? Identify the investigation. Name the, no, it is not pachymetry. Okay, Chandani says these are the endothelial cells. The answer is yes. These are the endothelial cells which you can see. So which test, which imaging is used to visualize, to study the endothelial cells? Tell me. Pachymetry is used to assess the corneal thickness. So pachymetry is for corneal thickness. So this is not pachymetry. Let's see. So now tell me, what is this? So I have told you what Chandani has asked. She has said, are these the endothelial cells? Yes, they are the endothelial cells. You're absolutely right. So basically, this is the investigation which studies or which analyzes the size, the shape, and distribution of endothelial cells. Now, anybody wants to make a guess? So, this is basically specular microscopy. This is specular microscopy. And if you see carefully, what do you see? You see these hexagonal cells. You see these hexagonal cells. If you see carefully, so what do you get to see? You see these hexagonal cells here with the center nuclei. So what is this? These are the, so what do you see now? This is the monolayer. You see the monolayer mosaic pattern of hexagonal cells. All right, so this is what we are studying, the size, shape, and distribution of endothelial cells, and this investigation is called as specular microscopy. So what do you see in the image are the endothelial cells. So endothelial cells in the cornea are a monolayer, they are a mosaic pattern of the hexagonal cells. And if you see here, the difference between the two, between this image is actually normal. This is normal. And what you see here, and if I enlarge the image, you see the cells have gone so large. See, the cells have gone so large. So when we talk of the corneal endothelium, remember the points that you should remember is the cellular density. You should know about the cellular density, which is more in the periphery, which go to the count of 8,000 cells per millimeter square than in the center, which are around 3,000 cells per millimeter square. So these are all the details we have already discussed in the anatomy of the cornea in the lectures. So this is what you have to revise. Then you need to know what is the decrease in the cellular count. Cellular count decrease has to be known per year. Also, when the count is less than 500 cells per millimeter square is when it is prone to corneal edema. Right? So now what do you get to see in this image? We all know the endothelial cells do not divide. So once we have a loss of the endothelial cells, they enlarge. So there is change in the shape and there is change in the size. So what do we get to see in this image? What we see is polymegathism and polymorphism. So by polymorphism is change in the shape and polymegathism is change in the size. So what you have to remember about the corneal endothelium is how we visualize it, what is the cellular count, how does it decrease per year, when does it predispose to corneal edema, what is the cell count when the keratoplasty or the tissue for the keratoplasty is accepted. All this comes, how do we preserve it so that endothelium is preserved. All these are important factors to remember. Eye banking and keratoplasty itself is an important topic. All right, so that is very, very important. All right, so we move on to the next one. So now when we move to this image, you have to tell me, these are 4 images. So image A, this is image B, this is image C, and this is image D. So now you have to match, right? Or if I can just label it like this, if I label these as 1 and 2, you have to match A and B, okay? So this is image B, this is 1, and this is 2. So now you have to match A. Is the staining pattern of A similar to 1 or similar to two? Tell me. So first thing is, yes, absolutely, Baljinder, this is corneal ulcer. Now you have to tell me what kind of, first, before we begin with anything else, what kind of a corneal ulcer is this? Tell me. Yes, absolutely right, Chandani. So what we see in A is the geographical ulcer. This is the geographical ulcer. And what is this? If that is a geographical ulcer, so this should be a spot diagnosis once you have it with staining. And what is this? Tell me. This is, so geographic ulcer is the image A. So what is image B? You're right, RGA corresponds to 1. But you have to tell me what is B. So B is basically the metaherpetic ulcer. So before I proceed further, we know what is geographic ulcer. When the dendritic ulcer, it worsens, it goes to form the geographic ulcer. And what is metaherpetic ulcer? Metaherpetic ulcer is once there is a healing problem. So once there is healing issues, it results in metaherpetic ulcer. And what is geographic ulcer? When the dendritic ulcer worsens. And when does this happen? This is normally when we use steroids, when the patient is immunocompromised, or it is a long-standing chronic ulcer. Then the dendritic ulcer would form a geographic ulcer. So now it is clear. So geographic ulcer is the worsening of the dendritic ulcer, and these are seen in cases of, what are we discussing? We are discussing viral keratitis. We are discussing viral keratitis. Okay. So now tell me which staining pattern corresponds to A. Neuropathic, nahi, it is neurotrophic. So most common cause of neurotrophic corneal ulcer is herpes simplex virus. But what you see here is not neurotrophic, it is metaherpetic. So neurotrophic leads to a metaherpetic ulcer. See the difference? So now, if you see image 1, so what the place where you have the staining in green, so this is the fluorescein staining. So this is the fluorescein staining, and the edges is the rose Bengal staining, and the edges are the rose Bengal staining. Is that pattern clear? So the central part, which is in green, is the fluorescein staining. This in green is the fluorescein staining, and the one in the sides, which is in red, is the rose Bengal staining. So this is the staining pattern which corresponds to the geographic ulcer. Whereas when we talk of the metaherpetic ulcer, what is, see, I have shown both in red for you to identify and learn this. So when you have an ulcer like this, so what here you have is the center shows red, which is rose Bengal staining. Which is rose Bengal staining with green at the edges. With green at the edges, which is the fluorescein staining. And this pattern is called as reverse staining. And this is called as reverse staining. So reverse staining is seen in metaherpetic ulcer. Is that clear now? So when you have the fluorescein, because the fluorescein stains the central ulcer base with the rose Bengal staining, the peripheral dichotomous branches with terminal bulbs is actually the geographic ulcer. Right? So rose Bengal basically stains the devitalized epithelial cells. Whereas I told you metaherpetic ulcer is a healing issue. There's a healing defect. So you have these devitalized cells, dead epithelial cells at the ulcer base. Hence, in metaherpetic, you have the rose Bengal staining at the ulcer base, and the fluorescein leaks out into the edges. Is that clear now? No confusion on this? Is that clear? Give me a thumbs up if this is clear to you. Then we'll move ahead. All right. Is that clear? Okay. Chandni says yes. Only one thumbs up is what I have got. So now when we are talking, yes. All right. So when we are, I'll skip a few slides. I'll come back to this before, but because here I am discussing the ulcers, so I want to discuss here. So here again, I have taken up viral keratitis just to complete what we learned when we talk of viral keratitis. And what viral keratitis are we talking of? We are talking of herpes simplex virus. And when I show you these images, what kind of presentation is this? Is it primary infection or is it reinfection of HSV? Tell me. So the images, if you get something to see like this, what are you seeing? Tell me, what are you seeing? Is it the presentation for the primary herpes virus infection, or is it the recurrence of the herpes simplex? Tell me. First, the first thing is, what is it? Is it primary disease or is it recurrent? So when you have these presentations, is it primary disease or is it recurrent viral keratitis, herpetic keratitis? Yes. So when you see these, this is not primary, these are the recurrent. So what in recurrent, we can have epithelial keratitis, we can have stromal keratitis, and so on. So when we talk of the epithelial keratitis, out of these, tell me which is the most common presentation of epithelial recurrent HSV keratitis. So these are the same. These are the same, which is A, this is B, this is C, and this is D. So out of A, B, C, D, you have to tell me the most common lesion of recurrent epithelial herpetic keratitis. Out of these, tell me, is it A, B, C, or D? So what you have to tell me is most common lesion which is seen in recurrent epithelial herpetic keratitis. Okay, so there are mixed responses between B and C. Can you name what is B? I will enlarge it. Can you name what is B? Tell me the diagnosis. What is B? What do you see on the screen right now? Okay, Chandni says you're confused between B and C. If you're able to name these, you will know the answer. So let's get on to the other side now, reverse side. So tell me, what is B? Absolutely, Panchanda. So what you see in B is, this is the dendritic ulcer. Absolutely. What is A? So if you see carefully, maybe not in the upper image, but here you can see these small lesions. So this is what is shown here. So this is basically punctate epithelial keratitis. So this is punctate epithelial keratitis. From here, they coalesce to form the dendritic ulcer. And from D, they can go to C or they can go to D. So from B, what is C? Now tell me, what is C? So the hint here is, once the dendritic ulcer heals, it goes and forms something like this. There it is not stain positive, but you can see some opacity in the stroma. What is that? The feathery-like lesion. These are the ghost images. So once the dendritic ulcer heals, it leads to a ghost dendrite. So this is once the dendritic ulcer heals. So once it heals, it leads to a ghost dendrite. That means now the cornea is not staining positive, but still you can see a dendritic-like lesion. And once it worsens, it goes to form something like this. So when I told you once it worsens, this is exactly what we discussed. It goes to form the geographic ulcer. It goes to form the geographic ulcer. So now no confusion. Chandani, you said there is confusion between B and C. So now tell me what is the answer. So the answer is the most common lesion which is seen in recurrent epithelial herpetic keratitis is dendritic ulcer. All right. So geographic ulcer is once this dendritic ulcer worsens, by that I mean we give the patient steroids, the patient is immunocompromised, the patient has a long-standing chronic ulcer which is non-healing, it goes to form the geographic ulcer, right? So that solves the confusion now. So now you all know what is the most common lesion which is seen in recurrent epithelial herpetic keratitis. It is B, which is the dendritic ulcer. Okay, all right. So we come back to the image here. So from where we started. So now, so next question we come to a 42 years old female. A 42 years old female reports to the OPD with complaints of retroorbital pain and diminution of vision. Fundus shows exudative RD with choroidal folds and produces an image shown below. What does the image suggest about the probable disease? So now if you see the image, let's see. Now here you are not supposed to tell me the finding, right? Just listen to the question carefully. You have to tell the probable disease. So the question is now tell me what is the answer. First you tell me what is the answer, then we'll discuss. It is the B scan. Absolutely right. So what is this investigation? This is absolutely right. This is B scan. The question itself says the B scan is shown here. What does the ultrasound image or the B scan suggest? So this is the B scan of the patient who is a 42 years old patient coming to you with retroorbital pain, with diminution of vision, with exudative RD, with choroidal folds, and this image. What is it? Tell me. Anybody who wants to attempt? So, okay, the option is B. If you say retinoblastoma, see, retinoblastoma should have a mass. Should have a mass inside. It should have calcification inside. So when we talk of retinoblastoma is classical to give you calcifications. There is no mass seen. So this you have to identify what are the parts that is seen. So this is the vitreous cavity, right? These are the coats of the eyeball. So this is the sclera and this is here, right? So now tell me, what do you see? Anyone now? So if this is the vitreous cavity, there is no mass seen, as you said, if it is retinoblastoma, there is no mass seen. So it is not retinoblastoma, there is no calcification seen. So this goes out. Then is it melanoma? Again, there is no mass seen. Melanoma can be flat or it can be pedunculated. So it has to have a collar stud appearance. It has to have a mushroom-shaped mass inside the ultrasound, but there is no echogenicity seen in the vitreous cavity. So this is also out. So again, we left with two things: secondaries and posterior scleritis. Secondaries, there need to be a lesion itself. Again, there has to be a malignancy that might be there. But if you see carefully, it says there is exudative RD which is seen here. So this is the exudative RD. You can see the fluid behind that retinal detachment, which is transparent. There is no mass seen. One thing, but that can be seen in secondaries also. So what is the classical sign seen here? If you see it, this, which is this sign? Tell me, what sign is this? Which sign is this? This is called as, anybody who wants to attempt, which sign is this? So what alphabet is being formed? Tell me. What alphabet is being formed? I want the answer from you. Then you will know. It is the classical appearance of posterior scleritis. Sclera is thickened. All right, I take that. But what is this sign called? This sign is classically called as T sign, which is seen on B scan, and this is the T sign. See, not Y, it is T. So this is basically the horizontal limb of the T, and this is the vertical limb of the T. So when you see here, this is basically the optic nerve that you get to see. This is the optic nerve which you see here, and this is the edema which is seen in the subtenons or the tenons space. Right? So this is what is the T sign is, and T sign is classically seen in posterior scleritis. The patient will complain to you of retroorbital pain. The patient will have, you are right, will have a thickened sclera, will have a thickened choroid, and will be having an exudative AD at times. And the classical sign to see in posterior scleritis is the T sign. So the vertical limb is because of the optic nerve, because of the edema around the optic nerve. What you see is the optic nerve vertical limb and the edema in the subtenons space, or in the space which is present above the sclera and below the conjunctiva or below the tenons is the subtenons space. So edema in that results in the formation of a T sign. Is that okay? Is that clear? So whenever you have an image like this, which is so predominantly showing the T sign, always think of posterior scleritis. So the answer here is posterior scleritis, the T sign. All right. So then we move on to this one. A mother brings her child in the pediatric OPD. In the pediatric OPD, that means we're talking about a child with signs of motor delays, hearing loss, intellectual disability, and poor vision. Neuroimaging reveals intracranial calcification. The image shown below is received from an ophthalmologist during the ocular evaluation. So that means fundus picture shows something here. What is the probable diagnosis? Good. So there's so many answers which say C, C, C. Yes. So here nothing has to do with whatever the question is talking about. It is so simple. Whenever you see a lesion at the macula, whenever you see a lesion which is right at the macula, pediatric patient coming to you with associated systemic anomalies like motor delays, intellectual disability, poor vision, lesion sitting right at the macula, has to be congenital toxoplasmosis. So when we talk of congenital toxoplasmosis, we all know it is caused by Toxoplasma gondii. It has two forms, congenital and acquired. So here you have a classical punched out lesion at the macula. Why? Because toxoplasma has a strong association, has a strong predilection for macula. So whenever you see an image which is affecting the macula and toxo is in the options, always consider it. Answer A. So what you said is there is confusion with how do you differentiate it from answer A. Very good. Now the answer A is headlight in the fog appearance. So when I talk of headlight in the fog appearance, please note, why is it called as headlight in the fog appearance? Number one, that is a feature of acquired. That is a feature of acquired toxo. One thing. Secondly, when it says headlight in the fog appearance, so that this fog word is basically pointing to vitritis, which is the predominant feature of acquired toxo. So whenever we talk of acquired toxo, it has a strong vitritis component. But since in this image, you see the image is so clear, there is no vitritis shown here. So hence A is not the answer. right? So do you get the difference? Headlight in the fog appearance is the appearance that we name for acquired toxoplasmosis. So whenever we talk of acquired toxoplasmosis, there has to be vitritis. And when there is acquired toxoplasmosis, the word used is headlight in the fog appearance. Again, the macular involvement. Had this had a very severe vitritis, then the answer would have been headlight in the fog appearance, which is acquired toxo. Is that clear? So whenever we talk of toxocariasis, toxocara can present in three forms. It can have a peripheral granuloma, it can be a posterior granuloma, or it can present as chronic endophthalmitis. All right. And cysticercus, we all know there's a beautiful cysticercus cyst which can be anywhere in the retina, anywhere in the orbit, anywhere along the globe. But whenever there is a question which is pointing to cysticercosis, please remember neuroimaging is very, very important to rule out neurocysticercosis. And the question will always eventually be pointing out towards that. Is that clear? Is that clear? Can we move ahead now? Pars plana banking. So whenever you talk of pars plana banking, it is pars plana banking is a sign which is more specifically pointing towards the intermediate uveitis. Yes, but when you talk of calcification, calcification is something which is seen in cases of congenital toxo, that is seen in cases of Sabin's tetrad. So what do you get in congenital toxo is a Sabin's tetrad. So you might or might not have pars plana banking. What you can have is this is the classical feature is the punched out lesion with calcification is what is more specific of a congenital toxo rather than saying a pars plana banking. Okay, is that clear? So if you say pars plana banking, that means it is intermediate uveitis. In intermediate uveitis, the primary site of infection would be the anterior hyaloid or the pars plana. But here the lesion occurs at the macula on the retina, so it is more posterior uveitis than the intermediate. Yes, headlight in the fog appearance ke liye, what the important thing that I have written here is acquired toxoplasma and it gives you vitritis. These two important words you have to remember. Okay, all right. So let's see. So now when I show you these images, first thing you have to tell me what is the diagnosis, and then if you want to name the images first, I know you will always tell me the diagnosis first. So you tell me what is image A, what is B, C, and D. You just have to tell me the name of the tests. Yes, I knew you, it will be spot on. This is easy, but all that you have, when you see the image C, it is always easy, but the other images also need to be remembered. So this is keratoconus. Now let's quickly see what the signs are. So in image, what do you see? In image A, what we see is there is an oil droplet like appearance which is seen on retroillumination, and this oil droplet is seen because of the apex or the base of the cone. Because of the cone appearance it is seen, and this is called as, no, this is not Munson's sign. What is A? Yes, Chandani has said oil droplet appearance, or it is called as the Charles sign. This is the oil droplet. This is the oil droplet reflex, or what is called as the Charles sign. All right, so then we come to image B. What is B? So when you throw a torch here on the temporal retina, you see the illumination on the nasal side in an arrowhead pattern. So which sign is this? Tell me. Which sign is this? This is called as the, anyone who wants to attempt? Which sign is this? This is the Rizzuti sign. This is the Rizzuti sign. This sign everyone knows. Once you try to look down, there is deviation of the, there is on the down gaze, there is deviation of the inferior lower lid margin, and this is called as the Munson sign. This is called as the Munson sign, and this is seen later in the disease. This is seen in cases of advanced disease. And what is this? So here, if you enlarge and see carefully, there is a ring here which is seen at the base of the cone because of the deposition of iron, and this is called as, this is not scissoring reflex, this is not Munson sign. What is this? This is called as the Fletcher ring. This is called as the Fletcher ring, right? So these are the important signs of keratoconus. Oil droplet or a Charles sign, Rizzuti sign, Munson sign, and the Fletcher ring. These are the important signs that you should remember when we talk of keratoconus. Yes, yes, absolutely, Gaurav. The Fletcher ring is because of the deposition of iron at the base of the cone at the level of the basal epithelium. All right. So now again we have two images, image A and image B. Tell me, what is image A? What is image A? So viral keratitis we have already discussed. So now tell me, what is A? So let's write down what do we see in image A. When we talk of image A, we have a single infiltrate, right? Okay, so Padya says it's fungal. All right, I take that, but let's see what do. So there's a single infiltrate, well demarcated edges. There is suppuration. That means there is pus here. There is associated, if you see, there is edema in the edges. There is surrounding edema. And there is this here. There is hypopia. Vis-a-vis, if we see, let's see now, let's write down what is we see in image B. So image B has, it is, you see the reflex is so dull here. This is so shiny. This is so dull. So this is a dry looking keratitis. There are ill-defined margins which are feathery. See, there are these feathery margins. There is one lesion here, one here, one here, one here, one here. So there are multiple lesions, which is called as the satellite lesions. Now, can you make it the difference? B doesn't have calcium deposition. This is just the feathery appearance of the ulcer. So now tell me, what is A? Now, anybody wants to change? So, single infiltrate, well demarcated, surrounding edema is bacterial or fungal? Yes, very good, Selva Kumar. Sorry, I'm sorry, Gautam Selva Kumar. I'm so sorry for mispronunciation. So that is a fungal. So B is fungal and A is bacterial. Absolutely right. So A is the bacterial ulcer. Why is it bacterial keratitis? How do you call it a bacterial keratitis? Number one, the important thing is single infiltrate, well demarcated edges, and there is hypopion with surrounding edema. So single infiltrate is very, very important. It is well demarcated with surrounding edema with hypopion. But the other side, if you see, when you have a dry looking ulcer with ill defined margins, the word here you have to remember is feathery. You have to remember the word satellite lesions. So whenever we talk of satellite lesions, it is what we are talking of is the fungal ulcer. What we are talking of is the fungal corneal ulcer. And the important thing to remember, if we talked of the hypopion here in fungal corneal ulcer, F means fungal, F means fixed. The hypopion is fixed in fungal corneal ulcer, whereas the hypopion is mobile in bacterial ulcer. Bacterial ulcer hypopion is sterile, whereas fixed is in fungal is non-sterile. That means there is a direct invasion into the anterior chamber in fungal corneal ulcers, even if the corneal epithelium is intact. So now you get the difference. F means fungal, F means fixed, and fixed hypopion is non-sterile. Whenever we talk of bacterial corneal ulcer, it is a single infiltrate, well demarcated, with surrounding edema, and the hypopion of bacterial ulcer is sterile and it is mobile. That means it moves with the movement of the head. Is that clear? Now, no confusions. Is that clear? So the important points that I have written here should be remembered. I will share the PDF of this session on my Telegram group, which is by the name of Dr. Bhumika I. And also till we reach the destinated day, I am going to put daily, I will be sharing some MCQs and their answers. So you can attempt there. Maybe we have discussed, maybe they are previous year questions, but it's the repetition, it is the revision which will take us forward. Is that clear? So now no confusion with bacterial and fungal corneal ulcers. No confusion about their appearance. No confusion about their hypopions. Right. So this we have already discussed. Now we come to the optic nerve appearances. Now tell me, what do you get to see here in this image? It is easy. It is very easy. The only things you have to differentiate what you see. So this is image A, this is image B, this is image C. These are all the affections of optic nerve disorder or optic nerve disease, or what we call is optic neuritis. So now you have to tell me, you have to name these variants. So when we talk of A, what is A? So when we talk of A, I tell you this is a patient who has come to you with vision like finger counting close to face, has RAPD, has red dyschromatopsia and a fundus picture like this. Name the disease. B, no. It is not B, which is retrobulbar neuritis. It is A, which is retrobulbar neuritis. Now, why is A retrobulbar neuritis? A is retrobulbar neuritis because retrobulbar neuritis is classically remembered as neither the doctor nor the patient sees anything. The patient does not see anything because he has the diminution of vision because of the disease, and the doctor does not see anything. Why? Because the fundus picture is absolutely normal. So that is exactly what you see. So if you have a normal fundus picture with the question talking about the signs and symptoms of optic neuritis, the answer would always be retrobulbar neuritis. The disc is completely normal. There is no edema. Nothing is seen abnormal in the image. So what do you do in such cases? We get a neuroimaging done. We get an MRI done. So that is one. So you have the question which is talking about the signs and symptoms typical of optic neuritis, but the fundus picture shows absolutely normal fundus is retrobulbar neuritis. The other thing is that when you get a picture like this, again the question is talking of signs and symptoms of optic neuritis, and a picture like this where the disc is edematous, what you see, the margins of the disc are not well defined. Right? There is disc edema. There is hyperemia of the disc. You see the vessels, they are so tortuous. So when you have a picture like this, then it is called as papillitis. It is called as papillitis because Itis means inflammation. Papilla means the optic nerve here. So this is papillitis. And when we go to the third image, where you have the image like B, plus what you get is these yellow deposits are the macula. So this is called as macular star. So when you get an image like this, which is B plus macular star, is called as neuroretinitis. Simple. Right, yes. So what basically lipid laden deposition is basically because you have edema around the macula which gets absorbed, and there are these lipid depositions which are seen at the macula. Right? So these are the variants of optic neuritis that you get. You have retrobulbar neuritis, you have papillitis, and you have neuroretinitis. Then coming quickly to the few other images that are important. I'll skip this. All right. So identify this image. So these are more important ones. Identify this image. What do you see here? What do you see here? Identify this image. So basically, what do we see in this image is there are a lot of sutures like this. All over 360-degree cornea has these sutures. So what is this? This is corneal transplant. Absolutely right. So this is not okay. Yeah. So this is the keratoplasty. This is keratoplasty, right? So, absolutely, this is a corneal transplant. And how do you identify? There are sutures all over. Sutures which are seen 360-degree are is keratoplasty. It can be a complete, it can be a total replacement of the corneal tissue when you replace all the layers of the cornea, or it can be a partial replacement of the tissue. When we talk of the partial replacement of the tissue, we call it as when you have a partial replacement of the corneal tissue, you call it as lamellar keratoplasty. Or there can be a complete tissue transplant. All right. So now we come to this image. Now identify this image. What is this? Which instrument is this? Anybody who wants to attempt? Which instrument is this? No, not related to Pangta directly. So if you see here, there is something here to hold and here to punch. Related to lens? No. All right. So this is basically the Garrison bone punch. So whenever we come to ophthalmic equipments, it always gives you shivers. It always gives you stress. So I have a class which is coming up on ophthalmic equipments. It is a free special class. So it is a free class. It is the free special class which is on the Unacademy app, which is on June 29th and at 5 p.m. So 29th June at 5 p.m. It is a 1 hour session that I will take from 5 to 6. It's basically, I'm starting with the series of the sessions on ophthalmic equipment. Every month, we will have 1 hour free special class on ophthalmic equipments. This time on June 29th, I'm going to discuss about the surgical equipments. So anybody who wants to learn more about the instruments is most welcome, because it's a free special class. Yes, it is a kerosene bone punch which is used in DCR surgeries. And just to leave, I will leave you with this image. What is this? Identify this. Anybody? What is this? Identify. Oh, you're welcome, Chandini. I know I've been getting so many requests on the Telegram group concerning this, so I just thought it is the right time to take this session. This is for Calazion curettage, Calazion clamp, Calazion clamp. All right. So I leave you with this question, and I see you on 29 on the other side of it. And I think a lot of people joined me late, so I would again tell you. So I'm basically doing this course for FMGE aspirants, which I'm conducting advanced ophthalmology and edge, which are 2 sessions. I am conducting 1.5 hour each. So there will be just 2 sessions, 1.5 hour each, along with mentorship before your exam. So these are planned on 10th, these are planned on 11th and 18th of July. So these are the plus sessions that would be conducted on the Unacademy app. So this is a short course of advanced ophthalmology, giving an edge over the others. The topics that I would be discussing here would be lasers in ophthalmology, eye banking, keratoplasty, Horner's syndrome, ROP, central serous retinopathy, and detailed analysis of the study, which has been asked so many times, on National Blindness and Visual Impairment Survey 2015-2019 and amblyopia. So these are the classes which I will be taking in this advanced ophthalmology course, which is an edge over the others. When you are done with the basics, you need to step on higher now before you sit in your exam. So these are the plus sessions, 2 sessions, 1.5 hour each, and it will soon be reflected on the Unacademy app. So anyone who wants to go a step higher towards your success, a step higher than what others are doing, you're most welcome to enroll for this session. So this will be on Unacademy app, published soon, and I'm telling you, this will be from 11th and on 11th and 18th July, 2 sessions, 1.5 hours each. So that is for today's session. Till we meet next, the next session, session 2 of FMG Must Know MCQs, is on 30th of June. So that is again the similar time, 6 o'clock probably. And then any details, any changes will be updated on my Telegram group, right? And the PDF of this session will again be will be uploaded on the Telegram group. And about the sessions, all the information will be updated on that group. And also, just to remind you that there is another class which is on ophthalmic equipments on June 29th. And on my Telegram group, we are running a MCQ series. Daily I will be posting some of the MCQs for target FMG. Till then, thank you so much for being such a nice interactive session. And take care, keep studying, keep revising. Wish you all the best.